We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Nikki, we're back. How are you?
I am doing well, Jess. How are you?
I'm great. So I have another joke for you.
I would expect nothing less.
So a virus walks into a bar and the bartender says, "We don't serve your kind here." And the virus says, "Well, you're not a very good host."
Oh, always the laughs with you, Jess. I appreciate them. Well, Jess, it's so good to hear from you and hear your jokes as always. Guess what we're talking about today?
What are we talking about today?
So our first article that we're going to talk about from Mohammed Ottaway is utilizing technology to increase efficiency of infection prevention data collection. Our experience using electronic medical records for symptom surveillance. How does that sound?
Fantastic.
Yeah.
It's awesome.
So Mohammed is the System Director of Infection Prevention and Epidemiology at Sparrow Health System in Michigan. He has over 23 years of experience in healthcare, with over 16 of those years being in infection prevention. Mr. Ottaway received a master's degree in infection prevention and control and is certified in infection control and in healthcare quality. He serves as a member of the APIC Practice Guidance Committee and uses his education and experiences to mentor infection preventionists and help them become certified in infection control. His research interests are healthcare-associated infections and IP competency and development. Welcome, Mohammed. We're glad to have you.
Thank you for having me today.
So start us off a little bit and tell us about your research and what prompted it.
Yeah, thank you so much for the question. First, I want to give a shout out to the co-authors on the paper, Cheney Manarin and Laurie Ellsworth, who are great to work with. Also, I think in infection prevention world, hospital and physician leadership support is key in achieving success when changing processes and working on quality improvement projects. Specifically, I want to acknowledge Dr. Paul Entler for his constant support. And I want to thank IT department for their great help in building the report used for this project in our EMR. So going back to your question, actually one of the APIC's 2019 competency models domains is infection prevention and control informatics. This is a newly added domain that describes how technology is evolving and how IPs must stay on top of this and leverage these systems to streamline processes, innovate our practices, and improve patient outcomes. When I got my master's degree in infection prevention, informatics was discussed but wasn't in the curriculum, so I felt there was a need to learn more about this and apply it to our work. This prompted us to conduct a quality improvement project to compare using electronic medical record reports to physical paper charts for surveillance. We intended to discover how much technology could impact our daily work by looking at one specific task, which was symptom surveillance.
That's really fantastic. We've actually been reviewing those competency model domains as well. So what is this symptom surveillance and why did you choose to focus on it in the paper? And why do you think it's so important?
So symptom surveillance is tracking how many patients come into the hospital with specific symptoms that might indicate an outbreak in the community. For our project, we focused on 5 specific symptoms, which were fever, cough, rash, vomiting, and diarrhea. If the hospital is seeing a lot of patients with any of these symptoms, it could indicate an outbreak of one of respiratory or GI infectious diseases in the community. So Being aware of this is very important, so our health system can prepare for more patients with similar symptoms, and also for health department where they can conduct more in-depth investigations and alert other hospitals for potential outbreaks and implement source control measures. Also, for the community, the health department can educate and guide the community members on how to protect themselves and how to avoid spreading the infection in the community.
I think that's amazing, because your paper talks about how much time that reduces on of the burden on the infection preventionists. So how do you think that technology is impacting infection prevention?
So technology allows for rapid identification of infections and trends. As we all know, computers are much quicker than people at sifting through notes and data and pulling out valuable information. So overall, technology is making us more efficient and successful at our work in infection prevention by two things: increasing accuracy and decreasing time and cost. Also, this allows us to identify outbreaks much quicker, often when they are still in their early phases, which enables us to respond quicker, leading to improved outcomes.
That's awesome, because these are all very important points that impact infection prevention and the infection preventionists' time. So in the methods section, you talk about how data was collected before you had EMR reports. Can you explain a little more about what that process looked like?
Before we were using EMR reports, we conducted symptom surveillance by sifting through physical patient charts, looking for patients that had at least one of the 5 symptoms of interest. When we saw a patient with a fever, cough, or any other symptom, we would tally those symptoms and count them all up at the end of the week to send them to the health department for syndromic surveillance. As you can imagine, this was labor intensive. It took our IPs at least an hour a day to complete this.
Yeah, that is quite a bit of work for the IP. I can't say that our system has really done it that way. We've done it a little differently, but that is a large time burden. So now that we have this technology, what does your process for data collection look like?
With EMR, we are able to work with our IT department to build reports that pull patient charts or numbers based on whatever we are interested in. So in this case, an algorithm was created that pulled a count of our specific symptoms. The report will run and generate the results of how many charts had any one of those symptoms noted in it during the week of interest, of course. And actually now the whole process takes less than 10 minutes compared to the previous process where that was taking at least 1 hour every day.
And I notice that you pull certain symptoms, certain word-based symptoms like fever, vomiting, cough, diarrhea. Can you clarify for our listeners how you exclude something that says with patient without diarrhea, or any other words that include, instead of vomiting, maybe emesis or throw up, puke? Fever might be written as afebrile or febrile. How do you how do you weed those
Thank
out?
you, Nikki. Actually, that's a great question. When we started the project, we talked to physicians initially about using traditional verbiage, but then decided to use the ICD-10 diagnostic codes when running a search to avoid capturing all symptoms. That will also address the challenge that you mentioned. You know that physicians will document, for example, no diarrhea, and we didn't want to capture those charts. Our method for gathering the pertinent population for syndromic surveillance mitigates the occurrence of false positives. And I think this is achieved by using a report that analyzes the patient's chart for ICD-10 diagnosis codes rather than keywords. Regarding fever data, the system searches for a documented temperature above 101 Fahrenheit in the patient chart. Also, and since that this is syndromic surveillance. The goal is to show trends and not specific to a case like how we do for CLABSI, where we need to look at every possible case and use a criteria to determine whether to count it or not. Whereas for syndromic surveillance, we collect data for symptoms and there's no criteria to be applied, and we monitor for trends to share with the local health department.
That's really fantastic. I know that searching for keywords can sometimes be a little bit challenging. So that all sounds like amazing methodology for finding what you're actually looking for. Now, technological literacy differs among different age groups and staff types. So was it difficult for the whole team to learn how to use this technology?
No, actually, it was very easy. Our IT partner taught the IP super user on how to find, save, edit, and run the reports. Then the IP taught the rest of our team. So everyone is able to do it. Actually, everyone caught on pretty quick. And IT has been great at being available for any questions that come up as time goes on.
So since this paper, with the success that you showed in your results, have you implemented more reports in your work?
Yes. With this technology, we are now able to do more thorough infection surveillance. For example, with healthcare onset versus community onset C. diff, now we are able to identify cases in the first 3 days of admission and count them as community onset cases. By doing this, we avoid counting more healthcare onset lab ID events unnecessarily. Also, our daily rounding has also improved. We are able to check isolation and infection status in real time and bring data with us when rounding to check that the isolation status, the EMR, matches the sign on a patient's door. We are able to focus on antibiotic stewardship and run reports on antibiotics prescribed during the day. We can look at trends of use and collaborate with pharmacy and physicians to determine if there is an increased sense or infections causing some trends.
It sounds like, so based on this work, you've actually had many successes and wins as a result of using this system. Are there any downsides to using the electronic medical records over paper records?
No, actually, I can't think of any. This technology adds flexibility to our jobs. EMR are also more environmentally friendly with less paper use, do not require large storage rooms for charts. Running reports enables quicker infection surveillance. Digital charts also reduce the possible spread of infections like MRSA, C. diff, and even TB and other infectious diseases that may be on a patient's chart contaminated from sitting in their room that then many healthcare workers will touch.
Yeah. How cool. That is such cool technology, and it's such a time saver. So, Mohammed, what do you see comes next? Like, in what ways do you hope or expect technology to continue to aid your work and infection preventionists' work in the upcoming years?
Yeah, for the future of technology and EMR, I look forward to more collaboration in EMRs between different health systems. This is really valuable when patients visit different hospitals to keep healthcare workers and IPs all on the same page about the patient's health, history of infectious diseases, and multi-drug resistant organisms, also prior antimicrobial treatments. I also expect the use of reports to increase for HEI surveillance, antimicrobial stewardship, and infectious diseases, and continue to make us efficient at our jobs, along with continuing to help us identify risks we were not able to before due to it being difficult or time intensive. Also will allow us to process and identify them early, especially for outbreaks where time is crucial for containment.
That's all fantastic. Thank you so much for joining us today. This is really amazing work, and we look forward to seeing more of this in the future. As Nikki and I in the infection prevention world always appreciate things that help us to increase our efficiency, but also increase safety to patients and staff. So thank you.
Thank you so much.
Jess, how cool is using the electronic health record now? Do you remember the days, or did you participate in the days where you had to sift through like lab reports and all kinds of micro reports? It was all paper.
We did. Yeah. It was not fun. And anything that we can do to make life more efficient in the world of infection prevention, I am definitely for. So
Indeed. I'm with you, sister.
So we have another interesting article to talk about next with Dr. Sharon Kramer. It's an evaluation of interventions to improve outcomes for hospitalized patients in isolation. And I feel like this is actually very near and dear to my heart because I feel very strongly about the outcomes of patients who have to be in isolation. So love this article. Dr. Sharon Kramer is an early career researcher and postdoctoral fellow at the Center of Quality and Patient Safety, Institute for Health Transformation at Deakin University. She has a background in physiotherapy and has worked clinically in stroke rehabilitation in the Netherlands. Dr. Kramer's research is focused on developing and testing non-pharmacological interventions to improve fitness and increase physical activity with a strong focus on consumer engagement. She has qualitative and quantitative research experience and has extensive experience in clinical trial designs. She has worked for several years at the Dutch and Australasian Cochrane Centers, supporting and teaching researchers about Cochrane's systematic review methods. Welcome, Dr. Kramer. We're so excited to have you with us today.
Thank you for having me.
So to get us started, do you want to just tell us a little bit about what prompted your research?
So I'm working in a bigger team. So I first want to acknowledge that this work has been done with the team at Deakin University, and the local team that I work in has done some work in patients in isolation, and especially now with this pandemic, to see what their experiences are. And so that prompted us to do this systematic review and see what's out there, and are there any effective management strategies to see if we can improve outcomes for these people in hospital that are isolated.
There's so much to talk about with this paper because it really goes into the effects that isolation has on patients, and it can be physical, quality outcomes, mental. Can you tell us about some of those before we get into a lot of our questions?
Yeah, so what we know from the research is that being isolated, maybe not just in hospital, but could be in a home setting, that isolation has negative effects on people. And that could be in the more mental health space, so mood and anxiety. But what we see in the hospital and the research that we found is that it could increase the risk of delirium, for example. People indicate that they are less satisfied with the hospital care when they're in isolation. There was a study that looked at people that were waiting to go into a rehabilitation setting but had to be isolated. And there is some indication that their outcomes are poorer than people that were not isolated at the start. So there's a delay in their rehabilitation. So as you say, it's a whole range of different things that could be negatively affecting people that are isolated in hospital. So
I'd like to talk more about patient concerns and anxiety related to understanding why they were being isolated. Let's explore that a little more. How patients understood what was happening to them.
Well, I think if you look at the literature in this area, it's from more qualitative research, the communication between hospital staff and patients is less. And what you see in one of the studies is that when you actually tell patients what's happening, what the procedures are, that could actually mitigate those effects on mental health and anxiety.
Yeah, I think, I imagine it could be concerning to observe your healthcare providers coming in and wearing, any number of different types of PPE and not understanding why they're wearing all of these things. So I could see definitely how that could cause increased anxiety. One of the questions that I had was there an average duration of isolation in the studies where it was more notable that patients had these adverse effects of isolation? So was there more like a specific period of time where you would expect to see some adverse events beginning, or was there a broad range of timeframes for this to occur?
That's a really good question, and that would have been great if the studies actually reported on those time frames. What we found in this systematic review, that we had a whole range of different types of studies, and I do have to say that in the review, even though we were aiming to find studies that looked at people that were in isolation for infection control, most of the studies that we were able to include were studies that had put people in isolation for protective purposes, so for immunocompromised patients. And I think that that's a very different group of patients, and the timeframes might be very different. But unfortunately, those timeframes were not very clearly reported in these studies. So we can't really tell if longer time frames, that's the idea, that with longer time frames, people are more anxious, possibly. But we couldn't explore that.
So let's talk about some of the interventions that you guys explored in the paper. There's music, psychological support services like musical therapy, dietary, nutritional management. I was curious about that and what that entailed. Physical activity, getting exercise, telerehabilitation. So I'd like to talk some more about what those interventions were, if you don't mind expanding on those.
Yeah, so one of the studies, I think, so let's start from the beginning. So most of the interventions that were tested in these settings were music interventions. And that comes from the idea that in other studies and in other populations, music can mitigate those effects on mental health in hospital. And there are some signs that music therapy could reduce anxiety and depression in people that are isolated. The interventions are very different, and as you can imagine, music therapy and music interventions can be a whole range of things, like playing music or listening to music, and that could be tailored to the individual patient. For the psychological interventions, we included a large study from China. The details of their psychological interventions were not very clear, but people got a phone call, for example, with the counselor, and as I said, the details are very, very much lacking in that study, so we can't say much about that. And one of the other studies, and I spoke about that before, that was an interesting study, and I think that goes back to informing people when they go into isolation, what it means, what it will look like, and really preparing people for that time in that isolated room, and that could have a positive effect on managing anxiety and depression in people that go into isolation.
Yeah, I thought that the music intervention was particularly interesting because it was so versatile, right? So it talked about the type of the music, the volume of the music, the dose of the music, but also, is the patient listening? Is the patient playing the music? were there any studies that talked about any one of those things being more helpful to the patient than others, or was it just more across the board that music seemed to be a helpful intervention?
Yeah, I think it's more a general that we can say something general about music that could potentially be helpful. Because in one of the studies, they actually had people playing music, like live music, outside the room because of infection control, obviously. But there's also, you can imagine now with what we have technology-wise, that we can have people actually listening to their own music and the music that they prefer and choose the music that they want to listen to, which could help, to stay calm in an isolated environment.
It's funny you mentioned playing music outside of the room instead of inside of the room because of infection prevention methods. And I was thinking, what would I want if I were in isolation in the hospital? And I think maybe like an unlimited number of crossword puzzles or Wordle. I've been obsessed with Wordle. But then I was thinking like, okay, so, everything has to be either disposable or cleanable. And you start going down a slippery slope with that. So what are some other interventions that you think could and should be studied?
That is a really good question. It's funny that you say that what that you think about what do I want. I just an anecdote. I had to isolate in a hotel when I was traveling back from the Netherlands to Australia, and I had to stay in that room for 2 weeks. And you do start to think about how can you make sure that you stay healthy and mentally healthy and physically healthy. And there's different things that you can do. Well, as I said, I think that nowadays with tablets, they are cleanable. You can mitigate the risks of infection. Mm-hmm. And where you can offer people different things like exercise programs mm-hmm. that people can do if they are fit enough. As you say, crossword puzzles, Wordle. I just started on Wordle, so I think that's a great. That would be a great intervention.
You just need an unlimited supply of Wordle instead of once a day.
Yes, not just one per day.
I don't know about Wordle, so I need to learn more about this.
I'll update you on it.
It's pretty good.
It's fun.
But I think there's several options that we can do. But I think that there's also a thing that about how we care for patients in isolation, that apart from giving them activities to do and mental and physical activities to do, I think it's also important that in caring for these patients, that we need to address some of the things which people are at high risk of getting anxiety and depression or worse outcomes, and maybe do a risk assessment before they go into isolation, and then have a more tailored approach to these individuals and say, well, we need to make sure that they eat well, or for this particular person, or if there's a false risk, that we put things in place to reduce those risks. So it's a very tailored approach, I think, that we need to look at.
Yeah, I think that makes a lot of sense. And those are really great points, even beyond the infection prevention realm. And notably, patients who are not able to have visitors, it creates this even larger struggle where, they don't have that human contact, other than those healthcare providers that are coming in and out of the room, and at what duration of time or frequency that they're coming in and out is generally limited, right? So, do you think that there's any value in, doing a study on how virtual visits with family and friends could potentially decrease anxiety and, these other adverse effects in patients?
Absolutely. We haven't talked about that yet, but that's a really, really good point. The team, my local team that I work in, they've done a qualitative study last year looking or interviewing families of patients that were isolated in hospital during COVID. And it's quite extraordinary how traumatic that was. And I think to put those things in place where people have social contact instead of clinical contact with their clinicians and their carers in hospital, I think that's really important. And I think in hospitals around the world, in our local hospital, that there's ways to do that in a safe way. It can all be set up. We are now so used to Zoom and these online platforms. So I think it would be a really good thing to look at if we have regular virtual visits, as you say, if that can actually reduce those impacts on mood and anxiety in people.
I wondered as I was reading this, when a patient is placed in isolation in the hospitals that you looked at in the study, when a patient is placed in isolation, did any of them have automatic default orders that address the patient's psychological well-being? I doubt it, because I don't think that is on the forefront of our minds, but I thought it would be interesting if when we place an order to put a patient in isolation, if there were automatic interventions that could be triggered.
No, none of the studies explicitly stated that they had a standard order in place in how to if there was a specific way of caring for these patients or specific procedures. So no, I don't think so.
Yeah, I really like that idea. I love that idea. And I think that there's a lot of, ideas that come to mind for me and how you could utilize an order set and, what types of interventions could be of value to patients. We have volunteers actually that will go around and read to patients. So that could be an option for a patient along with music or some other type of intervention. But then we get down to resources, and how do hospitals get resources to offer these interventions? Any ideas on that?
That's the big question, isn't it? Yeah, I think that at the moment, I don't know how it is in the US. I can imagine that it is the same at the moment. The staff in hospitals are really under the pump, and it's very hard to get extra time in to actually spend with patients. I do think, though, what you said before, with if you have a external carer, some of these things can be done by external carers or volunteers, setting up online meetings. You can play online games. You can read books on your tablets and things like that. I think that there's a lot of things that are possible and that might not cost that much.
It's definitely an under-resourced and under-researched area. And it sounds like we need to do a lot more investigating and researching on how to take care of our patients that we have to put in isolation.
Absolutely. I was surprised when we did the systematic review that we only came up with these 6 studies, which were not high quality studies. Because if you look back on the literature, the negative effects of isolation have been well described for a long time, but there hasn't been an effort to look at effective interventions or to come up with effective management strategies, I guess, to prevent these negative effects. But I guess there's also the tricky things with people in isolation, that you have to balance the risk of infection and your infection control in hospital, and making sure that these patients are cared for in the best possible way.
It's obviously really important research. So thank you so much, Dr. Kramer, for sharing what you found. And we look forward to other information that comes out about this.
Yeah, I think it's definitely opened up a whole world of questions and possibilities. So I think there's definitely more to be done on this.
Well, thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC, scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology, with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC, and APIC staff Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.